Good morning. I am Gokul Reshmi, Dr. Gokul Reshmi, Senior Resident from SLIMS. Today we are going to discuss about operative vaginal delivery. So what is operative vaginal delivery? Operative deliveries or vaginal deliveries, delivery of the fetal head accomplished with use of forceps or vacuum. So using a forceps or vacuum when we are delivering the fetal head or when we are delivering the fetus, it is called operative vaginal delivery. So how does it work? How does it work? What is the technique? So once either is applied to the fetal head, either the forceps or the vacuum, once either is applied to the fetal head, outward traction is generated. So force that augment maternal pushing to deliver the fetus vaginally. So what we are going to do, outward traction is generated and forces that augment maternal pushing. So already maternal effort will be there in case of maternal exhaustion or something. What we are going to do in order to cut short the second stage of labor, or in case of maternal exhaustion, we have to cut short the second stage of labor, or for any medical reasons where we don't want the maternal side to take more effort to deliver the baby. In that case, we are going to apply the forceps or the vacuum depending on the need, and we are going to give outward traction to deliver the fetus vaginally. The most important function of both devices is traction. So what is the point? What is the function of the device? Either the forceps or the vacuum is going to give traction on the fetal head or any part of the fetus. Okay, depending on the type of the forceps and where it is applied. And forceps used for rotation, particularly from occipital transverse and occipital posterior position. Okay, and the traction or simple lift out is for the outlet forceps. Okay, forceps rotation is for the forceps. Then what are the other events that take place during the operative vaginal delivery? One is the traction, other one is simple lift out. So incidence of operative vaginal deliveries varies widely, ranges from 3 to 5%. And vacuum is disproportionately selected and the vacuum to forceps ratio, delivery ratio is nearly 5 to 1%. Why the vacuum is frequently selected instead of the forceps? Because it causes less maternal and fetal trauma. So we will learn about the forceps. So these are the types of obstetric forceps, will be elaborately described later. So what is the history of obstetric forceps? Modern obstetrics, Peter Chamberlain in 17th century kept the secret of this forceps for nearly 150 years and surfaced it in 1813. Okay, forceps with cephalic and pelvic curves are described by Sir James Simpson in 1845, and detachable angled traction rods and traction handles are discovered by Murray in 1891. And rotation forceps for deep transverse arrest is invented by Keeland in 1915, and aftercoming head for the breech delivery is invented by Piper. That is called the Piper's forceps. It was invented in the year 1929. Short light forceps, generous cephalic curve is the Wrigley's forceps, and the pseudo-fenestrated belts is the Leucard's forceps, which was invented in 1937. Okay, what are the indications for forceps delivery when you will apply the forceps? So you can categorize the indication into maternal and fetal and others. So in maternal indication, if there is an inadequate expulsive force, if the bearing down effect of the maternal side is very less or very poor, if there is maternal exhaustion, then you are going to apply forceps. Or if where the expulsive force is contraindicated, like in case where there is suspect of hemorrhage, cephalic hemorrhage. Okay, so in those cases, cerebrovascular hemorrhage, cardiovascular disease like class 3 or class 4, or hypertensive crisis, or in case of myasthenia gravis, in these cases we don't want the mother to strain more. Okay, if they are going to strain more, it is going to endanger their life. So in these cases, we are going to cut short the second stage of labor. In case of spinal cord injury or risk of autonomic reflex or proliferative retinopathy where we suspect bleeding into the retina. So in these cases, we don't ask the mother to bear down. Okay, so in these cases, we are going to cut short the second stage of labor by applying the forceps and reducing the maternal efforts. So what are the fetal indications? Non-reassuring fetal heart rate or fetal distress. That is fetal distress. If the fetus is in distress, if the fetal heart rate is not reassuring, in that case, we are going to apply forceps to cut short the labor. In order to deliver the fetus early, we are going to apply the forceps. And in example, low birth weight baby, or in case post-maturity, we are going to apply the forceps and cut short the second stage of labor. After coming head of the breech or in the occipito-posterior or occipito-transverse position, in order to cut short the second stage of labor where it is highly prolonged compared to the other normal delivery, and also in phase presentation and ventral anterior to facilitate flexion and delivery of the fetal head. And in suspicion of fetal compromise, when there is fetal compromise, when you are suspecting imminent fetal demise, or if you are suspecting fetal distress, severe fetal distress, you are going to apply forceps and deliver the baby. So prolonged second stage of labor, other indications of where there is a prolonged second stage of labor, then we will call it the labor as prolonged if the second stage is prolonged more than 2 hours in nullipara and more than 1 hour in multipara. It is called prolonged second stage of labor. To cut short the second stage of labor, as in severe preeclampsia, cardiac disease, and post-cesarean pregnancy, we are going to use forceps. So when the forceps delivery is contraindicated, when we should not apply a forceps. So absolute contraindication and relative contraindications are there. So in the absolute contraindication, an unengaged head, if the head is not engaged, if it is floating, if it is high up, if it is at the brim or above the brim, we are not going to use forceps. Okay, unknown fetal position. If the fetal position is not known, we don't know whether it is occipito-transverse, occipito-posterior, or occipito-anterior. We don't know the position of the fetal head. In that case, we are not going to use this thing. Or in case of phase presentation, if we are not diagnosed, then we are not going to use it. And where are the two positions where we are not going to use forceps? It is absolute contraindication is mentoposterior and broke presentation. We are not going to use forceps. Forceps is contraindicated because it will damage the fetal phase and fetal tissue very badly. So relative contraindications of fetal bleeding disorder like thrombocytopenia or maternal HIV, which is going to cause aberration, and maternal fetal hemorrhage is going to be more if we are going to do operative vaginal delivery. So in those cases, we are not going to apply forceps. And encephalopelvic disproportion, where we suspect disparity between the maternal pelvis and the fetal skull, that is cephalopelvic disproportion, we are not going to apply forceps. In these cases, if we are going to apply forceps, what will cause? It will cause serious maternal and fetal soft tissue injury. Okay, and even in maternal side, it can cause complete perineal tear. So care should be taken, and proper identification and diagnosis of cephalopelvic disproportion is must before applying a forceps. So what are the prerequisites? What are to be there in order to apply a forceps? We have maternal criteria. In that, adequate analgesia has to be given. So maternal side, you have to give a proper analgesia, either the pudental nerve block or epidural anesthesia, whatever is needed. You have to give adequate anesthesia. The patient should be in a lithotomy position. A bladder should be emptied using red rubber catheter or a Foley's catheter. Completely empty the bladder. Position the patient in lithotomy position. Give adequate analgesia. And clinical pelvimetry must be adequate in dimension, size, to facilitate the atraumatic delivery. So I told you before itself, there should not be cephalopelvic disproportion. If there is cephalopelvic disproportion, it is going to cause serious trauma. For the cesarean section itself is far better. Okay, so we have to, in modern obstetrics, the aim is to avoid morbidity and mortality. So we have to properly assess the pelvis and must be having a proper pelvimetry. Okay. Then verbal and written consent has to be obtained for operative vaginal delivery. And the complications and the sequelae of the operative vaginal delivery also has to be explained to the patient. The proper consent has to be obtained. So how we will give the local block, perineal block or the pudental block. So first thing for episiotomy, what we routinely give is a perineal block, labial and perineal block for episiotomy outlet forceps. We can either do right mediolateral or left mediolateral episiotomy. So while giving episiotomy, we have to infiltrate the perineum with lignocaine, and once the perineum is infiltrated well with the lignocaine, then an episiotomy cut is given. So how we will give a pudental block? A 20 ml syringe is loaded. Is a 20 ml syringe with a 15 centimeter or 22 gauge spinal needle, and about 20 ml of 1% lignocaine hydrochloride is used for pudental block. So we are going to take 1% lignocaine hydrochloride, 20% we are going to 20 ml we are going to take in 20 ml syringe with a spinal gauge needle 22. We are going to insert the needle. Needle is passed into the vaginal wall on the apex of the ischial spine. So on per vaginal examination, ischial spine is identified, and thereafter we have to push it little to pierce the sacrospinous ligament. So we have to pass the sacrospinous ligament just above the ischial spine tip. Okay, about 10 ml of the solution is injected. Similarly, procedure is repeated on the either side to acquire adequate pudental block. Prerequisites are fetal criteria, vertex presentation. So fetal head must be engaged in pelvis. So for fetal criteria, fetus should be in vertex presentation. Fetal head must be engaged in pelvis. Fetal weight has to be estimated. Position of the fetal head must be known. Attitude of the fetal head and presence of caput succedaneum or the molding should be noted, and it has to be documented. And there should not be any fetal coagulopathy. Fetal thrombocytopenia has to be ruled out before applying the forceps, and no fetal demineralization disorder. So all the fetal conditions has to be fulfilled before applying the forceps. And what are the uteroplacental prerequisites? Cervix must be fully dilated in order to avoid cervical damage, and membranes must be fully ruptured, and you have to look for the color of the liquor, and no placenta previa. Placenta should not be low down, or there should not be any placenta previa in order to avoid the damage to the placenta. Other criteria: experienced operator must be experienced, trained with the use of instruments. Okay, so an untrained person can cause more damage. Okay, if you're not aware of the procedure, or if you're not trained in operative vaginal delivery, better stay away from the patient. So you have to get properly trained, and before applying forceps, a proper trained experienced gynecologist or obstetrician should be there. Okay, under their guidance, you can apply, or willingness to abandon the procedure, abandon the operative vaginal delivery in case of failure. If it is failed, you should be able to leave the procedure and go ahead with the other measures. Okay, you should not be repeatedly doing the procedure when it is failed. Okay, the capability to perform an emergency cesarean delivery if required. So if operative vaginal delivery you are going to do, and if it is going to be failed, then you should be able to do emergency cesarean delivery, and you should have the facilities to perform emergency cesarean delivery. Only then you can do an operative vaginal delivery. Okay, what are the prerequisites again? So full abdominal and vaginal examination has to be done. It should be 1/5 palpable, meaning it should be engaged. Cervix is fully dilated and membranes are ruptured. Station at the level of ischial spine or below for applying the forceps. Position of the fetal head has been determined, and caput and molding is no more the moderate, or it be more than +2. Okay, so pelvis is deemed adequate. Preparation of the mother, clear explanation is given, and informed consent and documented in women case sheet, and trust is established, and full cooperation sought and agreed with the women. So maternal bladder has to be emptied, in dwelling catheter has been removed, and balloon should be deflated in order to avoid bladder injury, and aseptic technique has to be performed. So operator must be trained, ability to do emergency cesarean section, the facility and the setup should be well versed, and there should be all operation theater settings and assistance for cesarean section. So we have to see the types of we are going to see the type of forceps. We have a long curved with axis traction device, then axis traction device with the handle, and release forceps and key lance forceps. So what is traction forceps? What are the traction forceps? The names are release forceps, Simpson's forceps, Elliott forceps, and Moray's forceps. So what is release forceps? It is the most commonly used outlet forceps. The action of the forceps is to give traction. It is simple lift out, and it is also used in the cesarean section. When the head is at the perineum, outlet forceps is used. The features of the forceps are: it is short, light forceps, cephalic and pelvic curves are there. The lock is English lock. And the Simpson's forceps and Elliott forceps are the low forceps, which is longer forceps compared to the Wrigley's forceps, because Wrigley's is short. It is outlet forceps. This is the low forceps, and that is why it is long. And cephalic and pelvic curves are there with an English lock. And Moray's forceps is the low forceps or the mid forceps, where there is axis traction forceps. Traction has rod and handle, has a cephalic, pelvic, and perineal curves. So English lock, nut and screws are available. Traction along the curve of Caras is applied. The other type of forceps is the rotation forceps. Rotation forceps are Keelan forceps and Barton's forceps. So these two forceps are mid forceps, where you have the cephalic and minimal pelvic curve. Pelvic curve is very minimal. You're going to apply rotation. So sliding lock is there, used in occipital transverse position in order to promote the rotation. Okay, so that is why it is named as rotation forceps. And to correct the asyncletism, you can use rotational forceps. So one blade hinged or slide lock or cephalic curve are present in the Barton's forceps. The special forceps is used for after-coming head in the breech delivery, that is the Piper's forceps discovered by Piper. And it is a long shaft. It has a long shaft, cephalic, pelvic, and the perineal curve. And it also has an English lock. So Simpson forceps is a low forceps which has fenestrated blade. Can you see this one? This one is the fenestrated blade. You have an opening in between the blade. There's the fenestrated blade, and parallel shanks are there. These two are the parallel shanks with the English lock. This lock is called the English lock. And you have the finger guard in this. You have left blade and the right blade, fenestrated blade, cephalic curve, and the pelvic curve. So accommodates the fetal head. Here you have the cephalic curve, which accommodates the fetal head. Then the most commonly used Wrigley forceps, it is an outlet forceps. It is a short curved obstetric forceps. Generous cephalic curve is there, which accommodates the fetal head. This is the cephalic curve, and the short shank, and then handle is there. And the lock here is the English type lock. Next is the Keelan forceps, which is a mid forceps. Okay, it has light weight. It is a lightweight forceps with a cephalic and minimal pelvic curve with a sliding lock. This lock actually slides. This lock works in a sliding mechanism used in occipital transverse position. It is used to correct and also used to correct the asyncletism. Next is parts of the forceps. For any forceps, the parts of obstetric forceps are two halves are there with a lock, fenestrated blade, and it has a shank, lock. Locks are English lock, nut and screw lock, and a sliding lock. We have clearly seen everything before. Then you have the handle and a finger guard for a grip. This is the finger guard, and this is the handle, and this is the shank and pelvic curve and the cephalic curve. And the perineal curve in some forceps, not all forceps. What does American College of Obstetrics and Gynecology says and classify about the forceps delivery? We have the outlet forceps, then we will apply the outlet forceps. Outlet forceps can be applied if the scalp is visible at the introitus without separating the labia. That is at the time of crowning, when the scalp of the fetal scalp is seen through the labia or to the introitus without separating the labia. That is the indication for applying the outlet forceps, and the fetal skull has reached the level of pelvic floor. Sagittal suture is in direct antero-posterior diameter or in the right or left occiput anterior or occipito-posterior position. Then fetal head is at or on the perineum and rotation does not exceed 45 degrees. You does not exceed more than 45 degrees of rotation. Then you can apply outlet forceps when the fetal head is in the perineum. When you will apply the low forceps, in low forceps, the leading point of the fetal head or the fetal skull is at the +2 station. That is 2 cm below the ischial spine or but more has not reached at the pelvic floor. When it is beyond the 2 cm from the ischial spine but not reached the pelvic floor. When it is at the pelvic floor, we can apply outlet forceps. When it is just above the pelvic floor and between more than 2 cm from the ischial spine, then we have to apply low forceps. Rotation is less than 45 degree for left occipito-anterior, right occipito-anterior or occipito-anterior, or left occipito-posterior, right occipito-posterior or occipito-posterior position. Rotation is more than 45 degree, including occipito-posterior position. So for the mid forceps, the head is engaged in the pelvis, but the presenting part is above +2. When the presenting part is above the +2 station, but the head is engaged, then we can use rotational forceps, that is mid forceps, that can aid in rotation also. The rotation is same as with low forceps. And high forceps is not included in classification as it is not used in modern obstetrics because it causes more morbidity and mortality. So for the use of high forceps, we can better go for cesarean section. It has less mortality compared to high forceps. So this is the image of maternal pelvis. This is one half of the maternal pelvis having the symphysis pubis anteriorly and the sacral and the coccyx in the posterior. This is the fetal skull that is descending through the pelvis through the curve of Caras. This is the curve of Caras. And this is the ischial spine. The point at the ischial spine is marked as 0. So above ischial spine, every 1 cm is counted as minus, and below ischial spine, every 1 cm is counted as plus. So when it is +5, it is completely out of the perineum, and when it is -5, it is above the pelvic rim. So +1, +2. We are going to apply the low forceps when the head is from here +2 to +4 or +5. That time we are going to apply low forceps, and we are going to apply a mid forceps when it is engaged but above the +2. We are going to apply mid forceps, and outlet forceps is applied when the head is at the perineum. So what are the morbidities? There is an increasing risk of certain morbidities for both mother and the fetus with operative vaginal delivery. So maternal morbidities and perinatal morbidities are high with forceps delivery compared to vacuum delivery. What are the injuries? That is complete perineal tear, okay, and tear of the anal sphincter can occur with operative vaginal delivery. Injuries are perineal laceration varying from perineal laceration, need for liberal episiotomy, and vaginal and cervical tears can occur. Post-traumatic or traumatic postpartum hemorrhage, then long-term urinary incontinence due to damage to the urinary sphincter or anal sphincter dysfunction can occur. Puerperal endometritis, because of prolonged handling, there can be infection in the endometrium resulting in puerperal time endometritis. Perinatal morbidities are soft tissue injury, facial nerve palsy. These are the soft tissue injuries. And this image shows the facial nerve palsy. Intracranial hemorrhage can occur. Cephal hematoma can occur. So these are the perinatal morbidity. And forceps delivery assessment before forceps delivery, we have to do both abdominal and vaginal assessment. We have to look for uterine contraction. There should be adequate uterine contraction, and at the peak of contraction, we have to give the traction to avoid fetal and maternal tissue injury, okay, and reduce the morbidity. So descent of the fetal head has to be ensured. Head should be engaged and it should be below +2 for applying low forceps, and fetal heart rate has to be monitored and it should be present. Weight of the baby has to be assessed, and cephalopelvic disproportion has to be ruled out. In vaginal examination, complete cervical dilatation is must. There should be full cervical dilatation. Membranes has to be ruptured. We have to look for the color of liquor. Then caput succedanum has to be assessed and has to be documented. Presenting part, what is the station of the presenting part, whether it is flexed or reflexed, how far it is flexed, and asynclitism is present or not. Position of the fetal head, whether it is left occiput, right occiput, anterior, posterior, or it is transverse, has to be identified, and accordingly forceps has to be applied, and accordingly traction or rotation has to be applied, and degree of molding has to be looked for. Degree of molding suggests cephalopelvic disproportion. When the molding grade is more, there is severe cephalopelvic disproportion. In that case, we are not going to apply forceps. So how do we apply a forceps? For occipito-anterior or left occipito-anterior position, the left handle of the forceps is held in the hand like this. Left handle of the forceps is held in the hand. The blade is introduced between the fetal head and the maternal pelvis, sides of the left side of the maternal pelvis, between the head and the fingers of the operator right hand. We are going to guide the blade with the help of the right hand. We are going to hold the handle with the left hand, and we are going to insert the blade. Insertion arc of blade, importantly, the thumb of the right hand guides the blade during the placement. So like this is the thumb of the right hand guiding the blade to place. So from here, we are going to turn the forceps like this, and we are going to place it in position. So once one side forceps blade is applied, applying the second blade, this first blade is held by the assistant. Insertion is generally generated by mainly by the thumb. So using the thumb, we are going to guide the second forceps, and we are going to lock the blade. Okay, the blades are constructed so that their cephalic curve is closely adapted. This is the cephalic curve that is closely adapted to the sides of the fetal head. So like this, if the cephalic curve is so close, this is the fetal head closely adapted to the sides of the fetal head, and we are going to construct the forceps, approximate the blades, and the fetal head is perfectly grasped only when the long axis of the blades corresponds to the occipitomental diameter. So this is the occipitomental diameter when the long axis of the blade corresponds to the occipitomental diameter, and then the blades are well applied. As a result, most of the blades lies over the lateral face. This is the lateral face. This is how the blade is lying. The sagittal suture perpendicular to the shank and equidistant from two blades. So this is the sagittal suture. The state is the sagittal suture. It is equidistant. It is equal from both sides. So equidistant to both shank and two blades. Okay. So there should not be any tilt or shift of the sagittal suture. The posterior fontanelle midway between the blades and 1 finger breadth anterior to the line joining the shank. So midway between this is posterior fontanelle, should be midway between the blades and 1 finger breadth above the anterior to the line joining the shank. So this is the shank, the line joining the shank. Here, from here, it is 1 centimeter. This is the posterior fontanelle. A small part of the fenestration of the blade to be felt on either side. So the fenestration, this is the fenestration. I have told you the sides of the blade has opening. That is called fenestration. So through the pelvic examination, a small part of the fenestration has to be felt through either side. So once you have delivered the head, how you will remove the forceps? It has to be removed very slowly in order to avoid fetal head injury or cephalic injury or hemorrhage. So branches are removed in the opposite order from that in which they were originally placed. So we have to remove the second forceps first and then the first forceps. The fingers of the right hand covered the sterile towel. So you have to give with the sterile towel, you have to hold the head and also the perineum in order to avoid sudden decompression. Okay, so the thumb is placed directly on the head to prevent sudden egress. Okay, if there is sudden egress, what will happen? There is going to be maternal and fetal trauma. So then what are the actions of the forceps? We are going to give traction. Outlet forceps is just simple lift out, and that is traction only. Upward traction is applied, complete extension of the head. To complete the extension process of the head, we are going to apply outlet forceps. And low forceps is horizontal until the head crowns, and then the perineum bulges, then followed by upward traction. So what we have to do, this is the outlet forceps we are applying, just going to complete the process of extension. Just lift up we are going to do. In low forceps, what we are going to do, horizontally we have to pull until the head reaches the perineum. Once the perineal bulging occurs, we have to uplift, we have to lift it up. And in mid forceps, first downward traction is given, and then forward traction, and then uplift. This is how we will apply traction in different forceps. So in occipito-posterior, you are going to give horizontal traction. So can you see here? This is occipito-posterior. This is the symphysis pubis, and this is the sacrum. Here the occiput is in the posterior of the maternal side. So horizontal traction until the root of the nose hinges on the pubic symphysis. Till this root of the nose hinges on the pubic symphysis, horizontal traction is given. And then delivery of the, until the, and forward traction has to be given up till the delivery of the occiput. Till the delivery of the occiput, forward traction is given, and then downward and backward traction for the nose, face, and chin to be born. So that is how we are going to deliver occipito-posterior. So the head should be flexed after the bregma passes under the symphysis pubis. Okay. In rotation forceps, if left occipito-anterior, the vertex is rotated from this position to the right occipito-anterior. So rotation less than 45 degrees, short rotation, short of full rotation, we have to apply. Application should be cephalic blades, cephalic with the blades over the parietal bones. Vertex rotates when traction is applied. If rotation is more than 45 degrees is needed, then we should try to manually rotate the fetal head. Then once if it is failed, but we have to try it first. If it is failed, then forceps can be applied, and the rotation occurs during traction. So wandering method for rotation in occipitotransverse. How do we apply the forceps? Application of the right blade of the keel and forceps, that is the rotation forceps, to the head of the left occipitotransverse position. The knob to the head in the left occipitotransverse position is applied. The knob will be ultimately face. Okay, the right branch is wandered to its final position behind the symphysis pubis. So from here we are going to apply, then it is wandered. It is wandered across the fetal head to reach the symphysis pubis, and then insertion of the left blade, keel and forceps directly below. This is the insertion of the left blade. Left blade is directly below the sacrum, hollow of the sacrum inserted, and then the sliding lock is applied, and then traction is applied in order to provide rotation. Okay, the blades are applied to the sides of the fetal head along the occipitomental diameter, with the pelvic curve directed downwards the neck, directed towards the neck, and downward traction is exerted until the chin appears under the symphysis pubis. Then by an upward movement, the face is slowly extracted, with the nose, eyes, brows, and occiput appearing in the succession over the anterior margin of the perineum. So how we will apply after coming head, the special forceps called the Pepper's forceps. How to apply? So we are going to hold the fetal body with a towel. We are going to elevate the fetal body. So fetal body is held, elevated using a warm towel, and the left blade of the forceps is applied to the after coming head. First we are going to apply the left blade. The right hand is going to guide the left blade, and the right blade is applied with the body still elevated. Other side blade is also applied. The forceps delivery of the after coming head is performed. After applying the two blades, blade is locked, and then gentle uplift traction is given to deliver the fetal head. So assisted vaginal births have that have a higher risk of failure should be considered a trial and be attempted in a place where immediate recourse to cesarean birth can be undertaken. So higher rate of failure are associated with higher BMI rate in maternal side. So maternal BMI greater than 30, that is in obese patient, the failure rate is high, and in short maternal stature, estimated fetal weight of greater than 4 kilograms for the baby or clinically big baby, or if we are suspecting cephalopelvic disproportion, then it can fail. And then head circumference above 95th percentile, where we are expecting if a big baby, and the cephalic percentile is going to be more than 95th percentile, and occipital posterior position where rotation is needed, and in mid pelvic birth where we are going to apply mid forceps, where the failure rate is high. When 1/5 of the head is palpable for abdomen, where we are going to apply mid forceps, the failure rate is very high. When difficulty is not anticipated in forceps delivery, but attempt fails is known as failed forceps. Difficulty is not anticipated in forceps delivery, but there is a failed attempt. It is called failed forceps. There is difference between failed forceps and attempt fails. Okay, so maternal and neonatal morbidity are high with the failed forceps. So forceps delivery should be abandoned if there is difficulty in application of the blade, there is no progress of descent with moderate traction, and delivery is not imminent after 3 pulls. These are the criteria to abandon the forceps delivery and go ahead with cesarean section. So, Love's principle of failed forceps. Forceps fail not only when the vaginal extraction is not possible, but also if after undue pulling, there is considerable damage to the maternal soft tissue or parts of the baby, which has been delivered, has suffered a considerable injury with a low Apgar score or nudge chance of survival. It is called failed forceps. Even after delivery of the baby, if the baby maternal or fetal morbidity is high, it is called failed forceps, even if the baby is delivered by forceps delivery. Okay, that is called Loeffler's principle. So VENTOUSE extraction, that is vacuum delivery. VENTOUSE is an instrumental device designed to assist delivery by creating vacuum pressure between it and the fetal scalp. So how the history of VENTOUSE is again James Young Simpson, double-valved piston with a metal cup was described by James Simpson, and Malmstrom in 1953 described the most successful model of the VENTOUSE forceps. Indications for VENTOUSE are same as those of the forceps delivery forceps, except that it can be employed in a phase or after coming breech. So vacuum forceps cannot be employed in after coming breech or in phase presentation, where vacuum is implicated only for cephalic or vertex presentation. So short second stage of labor, maternal exhaustion, presumed fetal distress, and occipital posterior position to deliver the second twin with the head is the presenting part. You can use the VENTOUSE forceps. What are the contraindications for forceps? Contraindications for vacuum delivery or gestational age less than 34 weeks. That is, in preterm babies, we are not going to apply vacuum because it is going to increase the intracranial pressure, and there can be rupture of minor vessels leading to intraventricular hemorrhage. And malpresentation, where the position is not known, we are not going to apply vacuum. And in case of cephalopelvic disproportion, same as that for forceps delivery, we are not going to apply vacuum. And fetal bleeding disorder, if it is suspected, like fetal thrombocytopenia, we are not going to apply vacuum forceps. And in maternal HIV infection, again, the chance of fetal-maternal or maternal-fetal hemorrhage is high. What are the prerequisites for vacuum delivery? Bladder should be emptied, cervix should be fully dilated, cephalic presentation is ensured, and head should be at least 1/5 palpable. It should be deeply engaged, and station should be +2 or below. If it is more than +2, or if it is in the minus station or in the 0 station or +1 station, vacuum cannot be applied. So what are the types of cup? Description and types of the vacuum or ridged cup, metal cup. Malmstrom cup is a ridged metal cup, and ridged plastic, polyurethane or polyethylene cups are also available. Soft cups are elastic cup and plastic cup, that is cubic cup. Bird cup is a tube attached eccentrically near the rim of the cup, used for occipito-posterior or occipito-transverse position. Soft cup and ridged cup, what are the difference? So more likely to have fail in soft cup, but there will be less scalp injury. Compared to the ridged cup, it is less likely to fail because it is going to adhere the nicely, it is going to get fixed with the fetal scalp, and there is more chance of scalp injuries, but the failure rate is very less. And it is more, soft cup is more suitable for occipito anterior, whereas ridged cup is suitable for occipito posterior and also in asynclitism and in large fetal head. So size ranges from 50 to 60 millimeter, and for ridged cup it starts from 40, 50 and 60 millimeter. CHIGNON is not formed in soft cup, whereas it is formed in ridged cup. So this is the types of vacuum. And metal cups and elastic cup, polyurethane cup. This is CHIGNON formation. The scalp is sucked into the cup, mainly in the metal cup. An artificial caput succedaneum is formed. In the procedure, it is sucked into the cup. CHIGNON usually disappears within few hours after delivery. CHIGNON in French meaning knot of hair that is worn in the back of the head like a bun. That is called CHIGNON. It is a word derived from the French. So morbidity, maternal outcomes and fetal outcomes. There is, as we have discussed, there is more morbidity associated with operative vaginal delivery compared to other deliveries. So what are the morbidities faced in the maternal side? Episiotomy, liberal episiotomy is given, and vacuum 50 to 60% morbidity, and forceps more than or equal to 90%. So compared to, in both cases, both operative vaginal delivery, there is morbidity, but it is significantly high with forceps, that is 90% morbidity in forceps and only 50 to 60% morbidity in vacuum. That is why it is preferred over forceps. So significant vulvovaginal tear can occur, vacuum 10% only, but in case of forceps it is 20%, and postpartum hemorrhage with vacuum and forceps delivery is approximately 10 to 20%, and it is almost equal for both. And urinary and bowel incontinence is common at 6 weeks, at first 6 weeks or in the 6th week, improves over time, mainly with the forceps delivery. So the morbidity in the perinatal outcome, Kefal hematoma and peri is predominantly with the vacuum, and with the forceps the fracture is more common, and facial and scalp laceration is common in both vacuum and the forceps. Facial laceration is not much seen in the vacuum, but in the forceps. Retinal hemorrhage is more common with vacuum than the forceps because of the pressure exerted intracranially, and variable, it varies between 17 to 38%, and jaundice and hyperbilirubinemia is associated with vacuum and forceps delivery as a result of hemorrhage, intracranial hemorrhage, that ranges from 5 to 15%, and subgleal hemorrhage predominantly associated with the vacuum because of the pressure exerted intracranially, that is from 3 to 6 in 1000 deliveries. And intracranial hemorrhage, vacuum and forceps delivery, it ranges between 5 to 15 in 1000 delivery, 10,000 delivery. And cervical spine injury is mainly associated with peel and rotation forceps, where you are going to apply in mid cavity. So it is quite rare. We are not that frequently using the rotational forceps nowadays. So skull fracture, mainly forceps and rare. Okay, mainly because of forceps. When you're constructing the forceps, if it is not properly applied, it can damage the skull, fetal skull, and result in fetal skull fracture. But it is quite rare. It occurs due to faulty application of the forceps. And facial nerve palsy, mainly by the forceps, and it is rare. fetal death is very rare. So this is the CHIGNON formation, and this is scalp laceration associated with forceps delivery. So how do you apply a scalp cup or the vacuum cup? The cup is placed against the fetal head near the occiput flexion, with the knob of the cup pointing towards the occiput. Okay, so that is called the flexion point, or the pivot point is an imaginary site located mid-sagittally about 6 centimeters from the center of the anterior fontanelle. So this is the center of the anterior fontanelle. From here, 6 centimeters from the center of the anterior fontanelle, that is the flexion point, and about 3 centimeters in front of the posterior fontanelle. This is the posterior fontanelle. From here, 3 centimeters, and from the center of the anterior fontanelle, it is 6 centimeters. That is called the flexion point or the pivot point, where you're going to place the vacuum. So what is the use of placing the vacuum in that point? It will facilitate flexion. Okay, that is why we are going to apply the vacuum in the flexion point. We want the baby's head to be flexed throughout the delivery. That is why we are applying in the flexion point. And suction, a vacuum of 0.2. So how do we apply suction? How do we calculate the weight? 0.2 kg per centimeter square is induced by pump, slowly taking at least 2 minutes. Okay, for every 2 minutes, you are going to, over 2 minutes, you are going to elevate the pressure of the pump. So check is made using the finger around the cup to ensure there is no cervical or vaginal tissue trapped inside the cup. If it is trapped inside, what will happen? Postpartum hemorrhage due to trauma will occur. Okay, then the pressure is gradually raised at the rate of 1 kg, 0.1 kg per centimeter square per minute until the effective vacuum of 0.8 kg centimeter per centimeter square is achieved. That is about 10 minutes it takes. Over 10 minutes, you are going to apply the pressure. The scalp is sucked into the cup and an artificial caput succedaneum is formed. So these are the vacuum pressure, millimeters and inches we are going to calculate. So the traction must be at the right angle to the cup. So we have to pull like this. Okay, traction must be given in the right angle to the cup, and traction should be synchronous with the uterine contraction. With the peak of the uterine contraction, traction is applied and traction is released between the uterine contraction. So traction should be made using one hand along the axis of curve of Caras. So this is the axis of curve of Caras, like a J or like a C. So that has to be applied along the curve of Caras. So this is how. So this is silicone cup, suction metal cup, and CHIGNON formation is the metal cup. So you're going to apply the flexion point and you're going to pull at the right angle. So along the curve of Caras. So this is the curve of Caras. This is the curve of Caras. Okay, so indicating the direction of the traction at different station of the fetal head. The second image, and traction over the flexion point at the pivot point either by VENTOUSE or the forceps promote flexion or present small diameter to the pelvis to facilitate the delivery. So operative vaginal delivery by forceps or VENTOUSE should be abandoned when there is no descent of the presenting part, or with each pull, or when delivery is not imminent after 3 pull, we have to abandon the procedure. Okay, and with correct application is very important. Okay, correct applied instruments by an experienced operator, and on no account traction should exceed 30 minutes and traction should not exceed 3 tractions. Okay, 3 pull. Okay, so how do we select? We have to rule out CPD and facilities. Abdominal examination, perineal examination, and pelvic examination has to be done. Cephalopelvic disproportion has to be ruled out. Weight of the baby has to be assessed. Position and position of the fetal head, presenting part has to be assessed. Whether it is rotation is completed or not, whether the head is engaged or not, all those things has to be checked for. And then have to empty the bladder. Adequate analgesia has to be given. Then liberal episiotomy followed by delivery of the baby. If there is going to be failure of 3 pulls or 3 pops of, we have to discontinue the procedure and go ahead with cesarean section. So the operator, whoever obstetrician who is conducting the operative vaginal delivery should be trained well to perform emergency cesarean section, and all the facilities for emergency cesarean section, blood transfusion should be available in the setup. Okay. So the relative merits of vacuum extraction and the forceps have been evaluated by Cochrane's systematic review of the 10th randomized control trial involving 2923 primary pairs and the multiparous women. What is the result is more likely to fail delivery with the selected instruments, more likely to be associated with cephal hematoma, more likely to be associated with the regional hemorrhage, and more likely to be associated with maternal worries about the baby. So that is less likely to be associated with significant maternal, perineal, and vaginal trauma, no more likely to be associated with delivery by cesarean section, no more likely to be associated with low or minimum bar of less than 5 per minute, and no more likely to be associated with need for phototherapy. Because of hemorrhage, there can be jaundice and need for phototherapy. So what is the advantage of the forceps over this thing? So forceps can be aided in rotation. It has to be applied. It can be applied in occipital transverse position in all positions, but VENTOUSE has its limit over the forceps. It can be applied only in the vertex presentation. Even with the 10 kg force can be applied in the forceps, but in vacuum it is not possible. And vacuum is contraindicated in preterm, whereas forceps can be done in the preterm, but forceps can cause more maternal and fetal tissue injury, soft tissue injury, but vacuum has limited fetal soft tissue injury and morbidity, that is around 60% compared to forceps, which is 90%, and easier to learn. And comparing to the forceps, vacuum is more easy to do compared to the forceps. Pop-off is not there in forceps, but it is seen in vacuum. In both the procedure, you should be able to quit the procedure and proceed to cesarean section. You should be well trained to perform emergency cesarean section, and adequate setup to perform emergency cesarean section is must. And also, you should be able to console the patient, convince the patient, and get a written and informed consent before any procedure. Thank you.